Okay, let's talk about Gitelman syndrome here, obviously. Distal convoluted tubules, the problem, this has nothing to do with your sodium potassium 2 chloride, does it? No. Gitelman will be dealing with your sodium and chloride channel. Now, what's interesting about this, take a look at the name. Hypomagnesemia, correct. Lose your magnesium. Hypokalemia, you lose your potassium, correct. However, this is the big thing. It's hypocalciuria. Now, understand that Gitelman syndrome is much more common than Bartter, granted, but no both for any of your exams. So here, in Bartter syndrome, there was hypercalciuria, and Gitelman, it'll be hypocalciuria. In Bartter syndrome, there was an issue with concentration of your urine. In Gitelman, not so much, but both will have issues with diluting. So these are things that you want to keep in mind when distinguishing one from the other. Continue. Autosomal recessive, there's the actual gene, SLC12A3, a gene product of NCCT. In other words, think about this sodium chloride channel. Thiazide sensitive. T, think thiazide. At least be able to identify that. You end up having this pretty much the same issue, except for one big thing. Hypokalemia, present both Bartter and Gitelman. Metabolic alkalosis, both in Bartter and Gitelman. Hypomagnesemia, both. Hypocalciuria. Okay? Whereas in Bartter, you had hypercalciuria, resulting in secondary hyperparathyroidism, correct? Normal blood pressure. You contrast the latter two findings, meaning the calcium and the blood pressure, to Bartter, and exactly the point that we made. Now, Gitelman, you usually diagnose until late childhood or adulthood, whereas in Bartter, childhood, we did antenatal. Remember the prostaglandin levels? They're quite high. In Bartter, more so. Hence the indomethacin and COX inhibitor. In Gitelman, it's not so much a concentrating ability, but its ability to properly dilute. Hence, the ADH will be suppressed, but that's pretty much in both. Cramps of the arms and legs due to hypokalemia, muscle weakness. What happens to resting member potential? One more time. Becomes more negative. You're further away from the threshold, so therefore more difficult to trigger an action potential. Welcome to fatigue. Maybe, perhaps tetany, polyuria, nocturia. Nocturia. That's pretty big in Gitelman. Approximately 80% of your patients could have nocturia. That's amazing. Now, why in Gitelman more so than Bartter? I couldn't exactly answer that for you, but look for this clinically because we know it occurs. Chondrocalcinosis due to chronic hypomagnesemia. Interesting concept. Unexpected hypertension may present later. Keep that in mind. However, you have enough information now to distinguish between Gitelman and Bartter. Please don't miss these questions. It's all here. Go back and review. I would say if you've never heard of these before, that you keep going over them a few times. If you have, review, and now you should be able to add in a little bit more information where you truly able to understand these conditions. Here, once again, for the most part, potassium sparing, ACE inhibitor. Sometimes with Gitelman, you'll have increased prostaglandin. I can't say for sure that you wouldn't with Gitelman. I wouldn't be doing justice. Clinically speaking, both Gitelman and Bartter have shown increase in prostaglandin, but more so in the Bartter that we talked about. Besides the drug action, we talked about the thiazide. This would be up in your distal convoluted tubule, and this would be more about your Gitelman. Remember the name of the gene there with NCCT, sodium chloride, and thiazide-sensitive type of area. With thiazides, it works in the distal convoluted tubule. Now, highlight this, both patient populations, meaning to say you have your African and elderly who have hypertension, oftentimes being the mainstay of therapy, and, important, thiazides behave like PTH. So, if your patient does have hypercalciuria, what kind of diuretic would you want to avoid? Loop, because loop would make the hypercalciuria worse. Thiazide would be used to, perhaps, remove the calcium from the urine. Please highlight in your mind, calcium renal stone formers. The drug attaches chloride, and by doing so, is able to then reabsorb the calcium. Now, there's a lot more mechanics to it, beyond the scope of your exams at this point, but clinically speaking, if you are thrown any question about thiazides or Gitelman on the distal convoluted tubule, you shouldn't miss them. Feel comfortable with it, welcome it. Thiazide hyponatremia due to loss of your sodium. Electrolyte abnormality includes your hypokalemia, metabolic alkalosis. Now, hypercalcemia is an uncommon complication. Keep that in mind clinically, please. So even though you know thiazides remove calcium from the urine, and so therefore those patients that you're worried about hypercalciuria genetically, or maybe due to, let's say, calcium stones or whatnot, you're not going to remove so much calcium that results in hypercalcemia. I can tell you that comfortably. Uncommon. More likely if the patient has primary hypoparathyroidism for obvious reasons. So if the patient is already in a state of primary hypoparathyroidism that we talked about, and use thiazide, of course, you might be exacerbating the issue. That's something that you do want to keep in mind.